So Paula, thank you for that nice introduction. And Janice and I will kind of do a duet. I'll talk for a few minutes, then the mic over to Janice, and then I'll make some closing comments. So it is truly a pleasure and honor for me to be here. It's an honor for me to share this mic and podium with Janice, who is in fact really our point person and Spina Bifida neural tube defect guru in our team. And I appreciated Paula, and she invited me to participate in our discussion. We have kind of a daunting challenge today. Here's the outline of our talk. We're really going to simply highlight important themes, recognize the initialism NTD neural tube defect, because we're going to talk about mostly spina bifida, but also mention the other anomalies that are part of this spectrum, this continuum, that are called the neural tube defects. So the purpose of our talk is really to overview these themes. You're not going to get any theme in depth. You're kind of going to get the highlights, if you will. And at the end of this talk, I would hope that you as a listener, or as they say in medical education, the learner, will be able to say a few words about each of these important themes. So first, let's just talk a moment about embryology. That is the study of the embryo and the fetus, which never stopped fascinating me in my more than 40 years in pediatrics and genetics. So again, we're only going to briefly highlight, which is a highly interesting topic, that is human embryology, and there are a very large number of web pages now that have three-dimensional videos, and if you become interested in this topic, I'd refer to, do a Google search, do Google image, and you'll be amazed what you'll find about 3D imaging regarding embryology. But as I suspect most of this audience know, that in the first 2 weeks of development, we have the embryo implanting in the mother's uterine wall. And then over the next 2 weeks, we have this complex process of becoming a two-layered individual, if you will, or developing structure, to actually having a third middle layer. One of my teachers used to say it was like an Oreo cookie. The white was the mesenchyme in between. And that between only 24 and 28 days, this process of this original notochord forming, and then this plate arising, this groove forming, and then closing from what we would think of as the back of the skull to the bottom of the spine, really zipping actually from the middle up and then from the middle down, and then closing the neural tube. So of course, then spina bifida and its the related birth defects, anencephaly and encephalocele, are arrests or alterations in this developmental process. Think for a second that, in fact, on average, someone conceives at 14 days after the last menstrual period. 2 weeks after that, which is 14 days of embryonic development, they've missed their menstrual period. 2 weeks after that, only 2 weeks after the mother has missed her menstrual period, the neural tube is already closed. So the alteration of the top part and the bottom part, top part resulting in anencephaly, bottom part myelomeningocele, related issues, has already 2 weeks completed after the last menstrual period. So you can see why the recommendation if folic acid is going to help has to be instituted prior to conception. Yes, ma'am?
I just have a question on that zipping up of the tube. It's showing that spina bifida most often occurs in the lower part. If it's zipping up at the same rate, does it sometimes occur in two spots?
It does. That's a logical question from actually what I said. So that, in fact, there are some children, some infants, some developing babies we know who can have multiple defects along the spine. Now, most of the time, the most complex defect, well, this should be an A right there, craniorhachischisis, where there is, in fact, an opening of the entire spine, but sometimes in that complex change, you can have multiple areas of closure. carrying on that theme, these are the types of neural tube defects. The open, which everyone here is familiar with, spina bifida. You'll see, by the way, Dr. Walker and others have said myelomeningocele. Sometimes you'll see meningomyelocele. The meningo are the coverings. The myel is the spine. The cele is simplistic word for cyst. So if you know the Greek, you can actually translate the word. Spina bifida, of course, Anencephaly, which is the upper alteration in brain development, which I suspect you're familiar with from knowing about spina bifida. Encephalocele, the most unique of the three types of findings, and then the rarest, which we only see a few times every few years in our Utah Birth Defects Network, craniorachis, that is, goes all the way from the entire spine. So here you can see actually the image where we have only meninges, only the coverings, versus also having the spinal cord itself. And Dr. Walker talked about some of these other variations, sometimes being hidden or occult. So of course the most common is the major theme of our talk today, myelomeningocele. Here's a nice diagram, I think from the CDC database, right? Isn't that where you, Janice, nicely took the slides? Again, you're all familiar. If we look at babies with neural tube defects, about 2/3 have myelomeningocele and about 1/3 have the Anencephaly encephalocele. We will talk about them because some of the basis of them, primarily the many genes that people are looking at and also the whole issue about folic acid, relates to both Anencephaly and Encephalocele. So there you can see most common form. You're all familiar with that 80 to 90% of children also have this defect that's up near the spine, the bottom part of the brain, the cerebellum, that's named after a doctor, Carey, the so-called Carey2, which probably is somehow secondary to this closure process and mechanical forces. It is not really a separate birth defect, if you will. So just like the secondary club feet, developmental dysplasia of the hip, sometimes other contractions below the lumbosacral defect, the tension related to the defect probably has an effect in the upper part as well. So again, Dr. Walker talked about the spina bifida cult. We won't talk about today, but it's really a local gap there that you see on X-ray but doesn't have any other definite secondary findings. We're not going to talk about that in detail. Most people don't have symptoms. Population is 15%, which is 1 in 6. And in fact, as has been studied in detail, parents of children with myelomeningocele do not have an increased occurrence of spina bifida occulta, although some studies have shown that there is. But when you look at all of it together, there probably is not an increased occurrence. So knowing whether spina bifida occulta is present in a parent doesn't really clarify risk. That is in the literature if you look at that in depth. And just population incidence, I have the spina bifida occulta. So Anencephaly, I suspect many of you are familiar with. Again, this picture taken from the CDC database. So here the defect is actually at the top part of the spine, really into the skull. This turns out to be most of the rest of the third after myelomeningocele. Interesting, there is a female predominance, and as we know, all infants with anencephaly die in the first few days of life. In fact, half are stillborn. The reports that we hear of babies with anencephaly who live longer actually usually have something else. It's often misstated that they actually have anencephaly. But again, because of its relationship in terms of ultimate cause, we wanted to at least discuss it briefly today as we talk about some of the prevalence figures. Encephalocele is the least common of the three, more common than the craniorachis, as I mentioned. Children with encephalocele can have it as part of the syndrome more often than spina bifida or more often than anencephaly. It has its own kind of unique genetic aspects for that reason, and again, we're not going to discuss encephalocele in detail. The developmental outcome depends on how much brain is in the sac or seal, and whether or not there's associated hydrocephalus and other effects on the brain. So I'm going to stop at this point. That kind of takes care of our first two parts. of our outline. Oh, and actually, we'll talk about prevalence when I come back on the stage, but Janice will not pick up. Oh, yes, sir, question.
Going back to one of the first slides, it's the repair surgery for the, I think it was the myelo, was done generally 24 to 48 hours after birth.
Or whatever Jeff Walker told you.
Is it generally before, can it be done before that or after that? Is it just generally?
It's generally, again, like Janice says, what Dr. Walker and Brockmeyer, Jay's here, I think usually they do try to make the repair. We want to watch out for infection. Certainly after that period of time, because we have, where's Jay? He's right here somewhere. We have babies transferred here that have been in outlying regions for longer, and we could still do the repair, but sometimes it can be more challenging, especially if there was a local infection. So they do try to stick to that 2 to 4 days, 2 to 3 days.
That was my question.
One thing I forgot to mention before because we didn't talk about prevalence, because I just kind of scooted it over on the slide. So prevalence is a fancy word for frequency. The overall frequency of all neural defects in America is around 1 in 300, 1 in 1,300, sorry, 1 in 1,300. That is just a little bit more than 1 in 1,000. I just wanted you to keep that figure in your head because we'll be talking about it in more detail. Let me turn the mic over to Janice.
Talk about being hard to follow someone. John Carey is the guru of malformations, so I'm honored to have worked with him for a long time. But some of you in the room may have started your spina bifida journey with prenatal diagnosis. Do we have any young families here who started their journey with an ultrasound or a phone call saying, oh, your screening test was abnormal, or you probably didn't hear anything after those words of, we need you to come back in and we're going to do more testing, or we're going to talk more about this. So I just want to acknowledge that we don't know what that's like, but I think Dr. Carey and I, over many, many years, have had families share with us what that's like. So I just want to acknowledge that prenatal diagnosis piece has actually sort of changed the spina bifida experience somewhat. But just briefly, we know from ultrasounds, many times we are able to detect spina bifida, either because of the shape of the baby's skull, or because we see the enlarged ventricles, or because we see a sac on the baby's back. Paula might be able to tell us, we know each year we still see a baby or two that's not prenatally diagnosed, but the vast majority of our patient population is diagnosed prenatally, either by ultrasound, or there are other biochemical markers sometimes used, so that blood screening test you had where they did quad screening or triple screening or AFP screening, and they found an elevated level of a certain chemical that raised our concern that a baby had spina bifida. Or some of you may have actually had an amniocentesis, which is where they use an ultrasound and they insert a needle and take a little bit of fluid out. And sometimes we're doing that because we want to not only confirm the spina bifida, but because we want to see if the spina bifida is part of an overall syndrome or condition, because that might affect management. It would definitely affect kind of the information we give you about what to expect down the road. So just a brief comment that if the spina bifida is covered by skin, this testing is, of course, more difficult and less sensitive. So when you guys come to clinic, lots of times one of your questions is, what do you mean this is genetic? Nobody in my family has spina bifida. I mean, this is all brand new information, and we know that probably 90 to 95% of the time, there is no one else in your family with spina bifida, but there still are genetic implications that we have to talk about. So, what's the evidence that spina bifida and neural tube defects are, quote, genetic? And genetic means different things to different people. So, we have what we call empiric risk studies. So that's, if we look at hundreds of families who've had a child with spina bifida, we can calculate what's the chance they would have an affected baby in a subsequent pregnancy. We know this number for Utah is about 3%. So if you come to clinic and we have a conversation, you'll hear that number. And then we'll have a much more detailed conversation about folic acid and how does it affect that number. And John's going to talk about that a little bit. The other number you may hear, I see a lot of young adults here with spina bifida. What's your risk of having a child with spina bifida? Again, the empiric risk data is about 5%. We'd actually expect those numbers to be about the same. And they're in the right ballpark, but that gives you a sense of what's the chance that your child could have spina bifida.
What's that chance?
So this is just, we don't have to talk a lot about this, but there is evidence out there that helps us come to this idea that there are some genetic factors involved. Twin studies and different studies looking at whether there are other affected relatives, and that we know spina bifida does occur in some chromosome abnormalities and some other syndromes that, again, would have different implications for a family if we diagnose one of these things. So we do recommend that families who have a child with spina bifida see a genetic counselor at some point along the way. And oftentimes at different points in your journey with spina bifida, it may be prenatally. How many of you had an ultrasound and saw a genetic counselor? See some hands. And sometimes you're in a place where you may or may not be able to hear a lot of information at that point. It's pretty overwhelming. So we'd like to see you after a baby's born. We have more information about the baby when the baby's here, that the baby just has spina bifida. There's not any other problems we're concerned about, so we can give you accurate recurrence risk information. As a part of that, we also will usually take a pedigree because that also affects what recurrence risk we would give you. And of course, prenatal diagnosis and folic acid are part of that discussion. So, how many people have asked this question? What causes spina bifida? How many, as you welcomed your new baby or you found out your baby had spina bifida, it's natural for moms and dads and all of us to want to know why our baby has something. And the bottom line, even John and I talked, if we gave this lecture 30 years ago, some of the answers would be similar in that you don't know for sure, but we do know more now. We do think that there's both genetic and environmental factors that are involved in spina bifida. And we're going to talk a little bit about this idea of a multifactorial model. So, who's had a genetics class in the last 10 years? Nobody, of course, okay. That's what we expected. So, many of you have heard about things being inherited, like cystic fibrosis. Is that something you've all heard of? Okay, see some nods in the room. So see if mom and dad carry a gene, if the genes get together, there's a 25% risk for the baby to be affected. Spina bifida like that? No. Or there's conditions where mom or dad have the gene, they can pass it on with a 50% risk of their child being affected. Is spina bifida like that? No. So spina bifida is relatively unique. There are other conditions that are inherited in this way in what we call multifactorial. So we think there are probably many genes involved. One of our challenges is figuring out which genes, of course. But they're not a dominant or a recessive gene. It's like the genes are all kind of pouring in to something and then they kind of spill over if you get enough of them. So we say that the loci act in an additive fashion, not that they're dominant or recessive. And then the environment piece, many people will tell me, oh, it's folic acid. We know folic acid is part of the story, part of the puzzle, but it may be more complicated than that. So this is just sort of a visual of this idea of multifactorial. So if we have more and more genetic factors and environmental factors, a very small percentage there will actually have the trait or have spina bifida. I'm not going to go through this in a lot of detail. We're trying to catch up in our time a little bit here. But this does tell you that most families who have a child with spina bifida, given this model, do not have spina bifida themselves and do not have spina bifida in their family. And that's probably true of most of the people in this room. And I won't worry a lot about these other things, but we do know in this model the more severe the defect, the risk in a future pregnancy may be slightly higher than in a milder defect. Let's get from there. going to have John Smith back up here in just a second. But one of the other things we think about and we talk about, and I may have asked you a lot of nosy questions and you're thinking, why is she asking me all these questions about my pregnancy? Is we know there are other risk factors for neurotypical defects. Of course, having had a previous child is a risk factor, or having a family history. Mothers who have insulin-dependent diabetes have an increased risk of a child with a neurotypical defect. We didn't talk about caudal regression, that's where the lower part of the spine doesn't form properly. That's also something we see in mothers who have diabetes. And the use of certain seizure medication. And these are medications called Depakote or Valproate or Tegretol. So I ask you in clinic about those things early on because we just want to document if those were risk factors for your child to have spina bifida. And then I'm going to turn over to John because we're going to talk a little bit about this idea of prevalence and ethnicity and whether or not there are any ethnic groups that have an increased risk of spina bifida. But the bottom line here, and you guys all know this, is anyone can have a baby with spina bifida.
I think Janice's slide is a good lead-in for the rest of the discussion because just to put this in perspective, each of these factors or variables actually only increase the risk to a small percent, usually a single-digit percent, so that prior pregnancy with NTD, the risk, as Janice pointed out, is about 3%. Family history of NTD, less than 1% of an increased risk, but much less than a doubling of the risk. Mother with insulin-dependent diabetes doubles the risk for the baby having a neurotypical defect of some kind. So I won't go through all of them in detail. When you get to race and ancestry, it's even smaller numbers. People will say, well, it's doubling the risk, but it makes it go from 1 in 13 or 1,500 to 1 in 7 or 800. So it's still, a doubling is actually still a small number. So keep that in mind as we go through some of this discussion about prevalence and also about folic acid. Those are the last few themes that we'll talk about. So there has been a lot of discussion since the, I won't say discovery, but since the learning that folic acid and even some other related B vitamins somehow play a role in that neural tube closure or lack of closure that we talked about earlier. But it's amazing, we've been talking about folic acid and related B vitamins since the late 1970s. Since the late 1970s. It wasn't until Smithel's paper in the late 1970s from Britain, unfortunately that very nice professor just passed away a few years ago, that he really brought this up. I won't go through that background. By 1987, there was a Center for Disease Control study that really identified this issue about folic acid, and then since then, that's 1987, all those, 26 years since then, we still don't know exactly how folic acid, parentheses, and related B vitamins, why they make a difference. We still don't know. There are many studies, there are many reviews you could look at, find them on the internet, but you won't come away with a walk-away answer as to something very simple. But one area that people are looking at is we already knew that different ancestries seem to have different risks. This is US data for spina bifida. So as I go through these numbers, pay attention to whether we're saying spina bifida, in this case SB, or NTDs, because some of the slides lump them all together, some of them separate them out. So you'll say, what? I thought he just said this figure, so be aware of that. So this is for people of Latino ancestry. So this risk of 4 per 10,000 really transfers to about 1 in 2,000, somewhere around there, which is again for spina bifida. Remember, the overall risk for all NTDs is about 1 in 1,300. But Latino families, including in Utah, this is US data, have an increased risk compared to African Americans and Asian Americans, and kind of European Caucasians are in between. So each of these figures will have, sometimes they really want to confuse us, don't they? They'll have different denominators, and they'll have, so you have to pay attention each time. So apologize for the confusion of the map. So these are actually Utah-specific data that Marcia Feldkamp, the director of our Birth Defects Network, just gave me this week. It's hard to go back earlier, so it's hard to go later, I'm sorry. It takes a lot of work to summarize 10, 11, 12, 13. So she's giving us this for this particular time period, and you can see that Native American and Latino families, numbers are smaller, but they actually have a higher risk than the entire group, and of course Caucasian Europeans, who make up the bulk, 90 or 85% of the Utah population. So you can see this figure is around 10 in 10,000, which means a little bit less than 1 in 1,000. Again, you have to think of these fractions each time. So we know there is some relationship to ethnicity, and that may have something to do with what I'm going to show you in a moment, that the actual frequency of Spina Bifida and all NTDs went down from 94 to 2000, and now is creeping up slightly. Again, we're talking about numbers, not people. But of course, we want the numbers to help us help people. So that's why I talk about the numbers. So at the little studies I told you about in the 80s, they led to more work from Europe and the UK, a great study from Hungary, that all led to the Center for Disease Control recommendations almost exactly 20 years ago on Christmas Eve. That's when they came out, Christmas Eve of 1993, that all women should be taking the 0.4 milligrams in their prenatal vitamin, which all prenatal vitamins have, prior to conception. That's all women in the general population. While women and mothers who have a previous child with any NTD, any neurotube defect, should be taking 10 times that dose, 4 milligrams. Those recommendations seem to not jive sometimes because they're based on the two big excellent studies. We didn't do a study for 2 milligrams in mothers who had previously had a child with NTD. If we did, I would guess we'd find that it was just as predictive. But we're kind of stuck with the 4 because that's what the European study did. There have been some studies that followed and some conflicting information, but at the end of the day, the synthesis is that the best data from Europe, from families who had a previous child, recommend this 10 times the usual dose that most people will have. Now, of course, prenatal vitamins usually include 1 milligram, so if we take them prior to pregnancy, we're covering the 1 milligram portion already. So I'm going to skip that slide there. So we know from these studies in Europe and the study from Hungary and then follow-up studies, observational studies all around the world, including the US, that of women who, whether it's a first pregnancy, second pregnancy, no history, family history of a previous child with NTD, that we reduce the risk by more than 50%. Some studies will say 60, some studies will say 70, but we about half the risk. So just keep that in mind. So since this all came about, since the 1990s, what recommendation to start using prenatal vitamins prior to conception, since that time, we have seen, and we don't have to necessarily pay too much attention to numbers here, we're talking about spina bifida. We've seen the frequency of spina bifida drop in the United States from roughly 1 in 2,000, see this 5 in 10,000, to less than 4 in 10,000. We've seen that drop. Food fortification occurred in the late 2000s, so this is actually pre-food fortification, and since fortification, we've seen it drop a little bit in some areas of America. But again, you've probably heard food fortification, which is primarily cereals, breads, and rice, only give half of the recommended dose. We're all going, duh? Why is that? Well, it's political. Again, we don't have time for that discussion. But I'm going to show you in a moment, it may be the next slide, that Chile decided to use the full recommended dose. Maybe that's the next slide. Nope, it's not the next slide, but it'll be coming up. This is Utah-specific data that Marcia again lent Janice, I, and Paula, going up to, again, 2008. So all neural tube defects, you see since we started really tracking this in 1994 through, the lowest point was 6 in 10,000. Again, I can't do the fraction quite in my head, but a little bit less than 1 in 2,000 for all neural, and we start a little less than 1 in 1,000 for all neural tube defects. Notice Spina Bifida also paralleled that decrease. And then when we get into the last decade, and this actually occurs for all ethnic groups, there's actually a slight rise again, and Encephalocele staying about the same. Again, the numbers are small because we have a lower population. That's why you get this jumping around of the figures. If you look at larger populations, it smooths out the curve. If you look at all the United States, it smooths out the curve. So we know that folate has a lot of different roles in the cell, but again, as I said a moment ago, we still don't know exactly how it causes this 50 to 70% protective effect that we're discussing. We know it affects homocysteine, which is also a risk factor for a whole lot of other health areas, even as adults. Stroke, high blood pressure, certain cancers, and coronary artery disease. So folic acid is even related to those risks as well. Again, tend to be very small, helpful factors. There are other roles it has, which I won't discuss in detail. Here's my Chile slide. I should have asked Janice to put it a little bit earlier, but so recently, data from Chile shows what food fortification has done in Chile because they're a very wheat-oriented, rice-oriented population. The general population is actually having the products that are fortified. They have a more than 2 times increased amount of folate, not the other B vitamins, but of folate in the products that everyone is consuming. And so overall, we can see from 1999 to 2000, before they fortified, that's in white, and in black, we have after 2000 when they fortified. So in all NTDs, we see that their frequency is about 12 in 10,000. So we see it's actually higher than 1 in 1,000. It's actually a higher risk than Utah and America for all NTDs. And you see that after food fortification, that number almost halved for NTDs in children with Chile. We see in Spina Bifida specifically, again, there was the 8 in 10,000, which would be just a little bit, would be around the 1 in 1,300. We're already talking about for Spina Bifida now, 1 in 1,300. And you can see that it went down actually to over half of that particular figure. Again, the numbers are one country and smaller. And you can see the effect for Anencephaly was less, but there was still some protective effect. Again, Marcia lent me this Utah-specific data that actually shows, so the white line is what we should be looking at. You can see that we're looking at an overall figure here of the figure of, let's see, where did I lose track of my number here? So about just over 1 in 1,000, and actually dropping here to about 0.6 in 1,000. But again, the number started to creep back up. So Janice told us about genes, and in fact, there are a number of genes that have been proposed to play a role. Of course, as you can imagine, the genes involved in folic acid biochemistry as well are the top of the list, but there are a lot of other genes. Most of them come from animal work. There are more than 200 mouse models in which the genetic aspects of the NTDs have been worked out reasonably well. But unfortunately, most of that work has not applied to us as humans as much as it has in other models where we use mice to help us understand biology, where it's still a lot of mysterious aspects. But of course, the folate pathway is our most important topic and attempts to sort this out. And I promise you, not only could I not do the biochemistry justice, but I won't give you the biochemistry in detail. But I noticed last night that one thing in this slide that we took from an article in the literature, and by the way, I Googled this last night, and if you Google image folate pathway, you'll find about 27 slides like this, and some of them are actually easier to follow than others. Long story short, this part of the folate acid pathway talks to this part of the folate pathway. But this particular protein, this particular enzyme that's right here that you've heard nicknamed MTHFR. Has everyone heard that MTHFR? That's the methyl tetrahydrofolate reductase. This particular enzyme that makes this particular reaction here occur, that interacts with the methionine part of the pathway. There are variants of this enzyme that are present in 30 to 50% of European Caucasian people. And it is found that if you find those variants, there is an increased occurrence of Spina Bifida. So and all neurotube defects. So there was a lot of hope that maybe really focusing on this particular enzyme and this particular path would eventually lead us to the secret. The long and the short is, if you read all the papers, and I've not read them all, but I've read a lot of them, you still end up walking away, which I don't really quite understand how it is that the folic acid, parentheses, and other B vitamins make a difference, but they do. So currently, we don't recommend that we have to draw levels for these enzymes prior to pregnancy in families of children who've had a child with Spina Bifida, in the general population in general, even though some of our OB colleagues are drawing that MTHFR level. It doesn't make any difference, and the current authorities on the topic don't see any reason to draw the level because do the enzyme, do the mutation study, because it doesn't make any difference in helping us. So in summary, hopefully we gave Janice, and there was some adding to that in my mind, because in some ways the multifactorial model is brought out by this folate along with genes we don't quite understand yet. Multifactorial model, the importance of folic acid supplementation. Janice did a nice job really highlighting all the genetic counseling issues, availability of prenatal diagnosis, and that is the end.